Hello everybody. Today we are going to discuss about the IDSA Guidelines 2024. So MDR, so first we will understand what is multi-drug resistance, what is XDR, and what is pan-drug resistance. So multi-drug resistance is defined as acquired non-susceptibility to at least one agent in three or more antimicrobial categories. Extensive drug resistance is defined as non-susceptibility to at least one agent in all but two or fewer antimicrobial categories. That is, if we are isolating one bacteria and if that is XDR, then that remains susceptible to only one or two categories only. And pan-drug resistance is non-susceptibility to all agent in all antimicrobial categories. So first we will see what is ESBL. ESBL is extended spectrum beta lactamase. So ESBL is the enzyme that inactivate most penicillin, cephalosporin, and aztreonam. So ESBL gene is more commonly prevalent in the gram-negative bacteria like E. coli, Proteus mirabilis, Klebsiella oxytoca, and Klebsiella pneumoniae. So ESBL enzymes are CTXM, TEM, SHV, beta-lactamase. So generally in most of the laboratories, this gene identification won't be possible. That's why if we want to identify the ESBL organism, we are how are we identifying? So if that bacteria, if that isolated bacteria is resistant to third generation cephalosporin, then that we can consider as a proxy marker for ESB. So once the bacteria is ESBL, then penicillin, cephalosporin, and aztreonam won't work against that. So how to treat this ESBL? So if we are treating with the clinical scenario like uncomplicated cystitis and if we have isolated ESBL, then we should treat it with the nitrofurantoin trimethoprim sulfamethoxazole, that is preferred approach. Alternative approach is ciprofloxacin, levofloxacin and carbapenem. Aminoglycoside is the another third option therapy, and phosphomycin, which we are using only for E. coli. If we are dealing with the complicated UTI, then the treatment options are trimethoprim sulfamethoxazole, ciprofloxacin, and levofloxacin. Alternative agents are ertapenem, meropenem, imipenem, silastane, and aminoglycoside. Then infection outside the urinary tract are meropenem, imipenem, silastane, ertapenem. So once we are getting the appropriate clinical response, we can switch to the oral trimethoprim sulfamethoxazole, levofloxacin, and ciprofloxacin. Piperacillin, cefepime, cefamycin is not suggested. And if it is CRE, then the treatment option is ceftazidime, avibactam, meropenem, vaborbactam, imipenem, silastine, relibactam, ceftriaxone, tazobactam, and cefiderone. Then the next class is AMC, that is AMC beta-lactamase producing enterobacter. So AMC beta-lactamase are enzymes that are produced by a number of enterobacter and the glucose non-fermenting gram-negative organisms. So the main function of the AMC is to assist with the cell wall recycling. AMC beta-lactamase, these are capable of hydrolyzing number of beta-lactamase agent. So increase AMC enzyme production resulting from the inducible AMC expression that can occur in the presence of specific antibiotic. And what are the specific antibiotics? It is ceftriaxone, cefotaxime, ceftazidime, aztreonam, piperacillin, tazobactam. So, this bacteria is this type of the bacterial resistance is very smart because first, if we'll isolate this organism, then that will show the susceptibility to the particular drug, let's say ceftriaxone. Then after starting this antibiotic, this bacteria will develop the AMC enzyme, and that will increase the minimum inhibitory concentration of that antibiotic. Now that bacteria is non-susceptible to that particular antibiotic. So we will think, so if that particular XYZ bacteria is susceptible to this drug according to our anti-sensitivity testing report, then why it is not acting against the why my patient is not improving. So in that scenario, we should always consider the possibility of the AMC. So enterobacterales isolate initially test susceptible to ceftriaxone, but Later on, they may exhibit non-susceptibility to this agent after treatment with ceftriaxone is initiated. So the MC is quite tricky one. The another mechanism is stable chromosomal deprivation and constitutively overexpressed MC gene. So MC production is always increased. So isolates with either of these two mechanisms typically test non-susceptibility to ceftriaxone, cefotaxime, and ceftazidime. And the MC gene is black, black MY, BLA-FOX, BLA-DHA, BLA-ACT, and BLA MIR. This MC gene can be found either on plasmid or it can be integrated with the chromosome. So beta-lactam antibiotic fall within the spectrum of potential for inducing MC gene. Now this aminopenicillin, that is amoxicillin, ampicillin, narrow spectrum, that is first generation cephalosporin, and cefamycin, these are the potent MC inducers. Imipenem is also potent MC inducer, but it remains stable to the MCE hydrolysis. Artepenem, meropenem, these are the stable MC hydrolysis. Ceftriaxone, cefotaxime, ceftazidime, piperacillin, tazobactam, and aztreonam, these are relatively weak MC inducers. Now again, the treatment option is divided into drug treatment for uncomplicated cystitis, complicated pyelonephritis, and infection outside the urinary tract. So if it is uncomplicated cystitis, then the treatment options are nitrofurantoin and trimethoprim sulfamethoxazole. Then the alternative treatments are ciprofloxacin, levofloxacin, and aminoglycoside. For complicated pyelonephritis, treatment options are trimethoprim sulfamethoxazole, ciprofloxacin, levofloxacin, and aminoglycosides are alternative treatment. Now, if there is infection outside the urinary tract, then cefepime is suggested. Transition from the cefepime to the oral trimethoprim sulfamethoxazole, ciprofloxacin, or levofloxacin should be considered if susceptibility is demonstrated. And the antibiotics which are not suggested are ceftriaxone, piperacillin, tazobactam, and nevirapine. Now the next class is carbapenem-resistant enterobacters. CRE is defined as the member of enterobacter resistant to at least one carbapenem antibiotic, that is ertapenem, meropenem, imipenem, doripenem, or producing carbapenemase gene. Resistant to at least one carbapenem other than imipenem is required for bacteria intrinsically less susceptible to imipenem. That means if we are tackling with protease, morganella, and providentia, then these bacteria are somewhat intrinsically less susceptible to the imipenem. So when we will call it as CRE, so when these bacteria are resistant to imipenem as well as to the other agent of carbapenem class, then we can label it as CR. So this is the classification of carbapenemase beta lactamase, which is broadly divided into serine beta lactamase and metallo-beta lactamase. In serine beta lactamase, the serine beta lactamase include KPC, then our ESBL, the AMC, and OXA, and MBL include NDM, VIM, and IM. So mostly for carba CRE, to tackle with CRE, we are using ceftazidime, avibactam, and aztreonam. So if we are tackling with this NDM, if we are tackling with this MBL, then mostly the avibactam won't work against this. So the preferred treatment option is aztreonam, and this avibactam is work. Avibactam will work against this serine beta lactamase. That's why if we are isolating OXA or KPC, then the treatment of choice is ceftazidime, avibactam, not aztreonam. Tackling with the uncomplicated cystitis, then the treatment option is nitrofurantoin, trimethoprim sulfamethoxazole, ciprofloxacin, and levofloxacin. Or we can go for aminoglycoside, oral fosfomycin for E. coli only, then colistin, ceftazidime, avibactam, meropenem, veibarbactam, imipenem, cilastin, relebactam, and cefiderocol. If it is complicated cystitis, then the treatment option is trimethoprim sulfomethazole, ciprofloxacin, levofloxacin, a preferred treatment option for pyelonephritis and complicated UTI caused by CRE if susceptibility is demonstrated. Then the other treatment option is ceftazidime, avibactam, meropenem, vaborbactam, imipenem, cilastin, relebactam, and cefidecrol. Aminoglycoside is the alternative agent. Then, if we are tackling with the infection outside the urinary tract, then we should see whether it is KPC, NDM, and OXA. If it is KPC, then the treatment option is meropenem, vaborbactam, ceftazidime, avibactam, imipenem, cilastin, relebactam, and cefidecrol is the alternative option. If it is NDM, then the ceftazidime, avibactam, usually in combination with aztreonam, and cefidecrol is the monotherapy. Usually they are saying if the bacteria is NDM, then it is also positive for OXA. Therefore, whenever we are isolating NDM, we are starting the combination treatment of ceftazidime, avibactam plus aztreonam. And if we are isolating OXA, then ceftazidime, avibactam is the preferred treatment option for OXA 48 like producing enterobacter, and cefidecrol is the alternative option. Now, CRA outside the urinary tract that are not carbapenemase producing. For infection caused by enterobacterial isolate that are not carbapenemase producing and that exhibit susceptibility to meropenem and imipenem but not to ertapenem. That means if minimum inhibitory concentration for ertapenem is more than or equal to 1, then we can tackle this situation by using extended infusion of meropenem. And the treatment line which are not suggested is tetracycline, polymyxin, colistin, and the combination antibiotic therapy. That is use of beta-lactam agent in combination with aminoglycoside, fluoroquinolone, tetracycline, and polymyxin. Now the next is Pseudomonas aeruginosa with difficult to treat resistance. So what is MDR Pseudomonas aeruginosa and what is difficult to treat Pseudomonas aeruginosa? To understand this, we should know what are the drugs which are acting against Pseudomonas aeruginosa. Because there are very few categories and category also very specific drugs are there that are active against Pseudomonas aeruginosa. So among beta-lactam antibiotic, in penicillin, it is divided, the penicillin group, the drugs which are active against Pseudomonas aeruginosa is carbacillin, ticarcillin, azlocillin, mazlocillin, and piperacillin. Then in monobactam, aztreonam, then cephalosporin, ceftazidime, cefoperazone, cefepime, cefepirone, carbapenem group, imipenem, doripenem, and meropenem. Then in aminoglycoside, tobramycin, amikacin, and gentamicin. In polypeptide group, poly B colistin, quinolone, ciprofloxacin, levofloxacin, pfloxacin. So now we will understand what is MDR. MDR Pseudomonas aeruginosa is defined as Pseudomonas aeruginosa that are not susceptible to at least one antibiotic in at least 3 antibiotic classes for which Pseudomonas aeruginosa susceptibility generally expected. That is penicillin, cephalosporin, fluoroquinolone, aminoglycoside, and carbapenem. So in 2018, the concept of difficult to treat Pseudomonas aeruginosa was proposed. So what is difficult to treat Pseudomonas aeruginosa? Difficult to treat Pseudomonas aeruginosa means non-susceptibility to all of the following. That is, it will be non-susceptible to piperacillin tazobactam, ceftazidime, cefepime, aztreonam, meropenem, imipenem cilastin, ciprofloxacin, and levofloxacin. So MDR Pseudomonas aeruginosa. When Pseudomonas aeruginosa isolate is susceptible to both traditional non-carbapenem beta-lactam agent and carbapenem, then this non-carbapenem beta-lactam agent are preferred over carbapenem. That is piperacillin tazobactam, ceftazidime, cefepime, and aztreonam. For infection caused by Pseudomonas aeruginosa isolate, non-susceptible to any carbapenem agent, but susceptible to traditional beta-lactam, the administration of traditional non-carbapenem beta-lactam as high-dose extended infusion therapy is suggested. So, the use of newer beta-lactam agent to which Pseudomonas aeruginosa is susceptible, that is ceftolozane tazobactam, ceftazidime avibactam, imipenem cilastin relebactam is also reasonable treatment approach. Then again, it is divided into uncomplicated cystitis, complicated pyelonephritis, and the infection which are occurring outside the urinary tract. Uncomplicated cystitis. Uncomplicated cystitis is caused because of the ceftolazone tazobactam, ceftazidime avibactam, imipenem, celestine, relibactam, cefiderocol. These are the preferred option for uncomplicated cystitis caused by difficult to treat Pseudomonas aeruginosa. Then tobramycin, amikacin, and colistin. These are the alternative options. Now, for complicated pyelonephritis, what drug where that we can use is ceftalazone, tazobactam, ceftazidime, avibactam, imipenem, celestine, relibactam, and cefadecol. Once daily tobramycin and amikacin, these are alternative agents. Now, if there is infection outside the urinary tract, then we can use then also we can use the same drug, that is ceftalazone, tazobactam, ceftazidime, avibactam, imipenem, celestine, relibactam, and cefadefdol is the alternative. MBL, if it is MBL, then it is cefiderocol. Remember, combination antibiotic and nebulized antibiotic are not suggested. Now, the next organism that we are dealing with, carbapenem resistant Acinetobacter baumannii. Now what are the challenges that we are facing when we are dealing with this crab is, first is crab is most commonly isolated from respiratory specimen and the wound. So it is not clear whether this crab is a colonizer or it is actually true pathogen which is causing infection. Now, the second challenge is Acinetobacter baumannii exhibit carbapenem resistance. It generally has acquired resistance to most other antibiotics, which are expected to active against wild-type Acinetobacter baumannii. So, we are actually left with very few therapeutic options. So, if it is oxacarbapenemase, then that mediate resistant to beta-lactam, including carbapenem and also sulbactam. So crab isolates, which produces the additional serine beta-lactamase, that is Acinetobacter baumannii derived cephalosporin, then that limits the further utility of common beta-lactam agent. So, if there is a mutation in the penicillin binding protein, then there is a resistance to sulbactam also. If there is a mutation in the modifying enzyme and 16S rRNA methyl transferase, then that is responsible for aminoglycoside resistance. If there is a mutation in the chromosomally encoded quinolone resistance, then it is resistant to fluoroquinolone. So additive benefit of commonly used combination regimen for crab, it remains incomplete. So what are the treatment options that are available? So general approach is the preferred treatment regimen is sulbactam, durlobactam in combination with the carbapenem. And the alternative agent is high dose ampicillin, that is sulbactam, total of 9 gram in combination with at least other agent, that is polymyxin B, minocycline, if sulbactam, durlobactam is not available. Then suggested approach. Combination therapy with at least two agents whenever possible is suggested for the treatment of crab infection, at least until clinical improvement is seen. Now we can now what are the treatment options that are available as a that we can start as combination therapy. So we can start with a polymyxin as a combination with at least one agent. Then high dose minocycline and high dose tigecycline can be started as a combination therapy with other agent that shows susceptibility to the crab. Then cefiderocol also should be limited to the treatment of the crab infection, which are refractory to the other antibiotics. Now, not suggested is meropenem, imipenem, celestine, rifampin, and other rifamycin, and nebulized antibiotics are not suggested for the treatment of the crab. Now, the next is Stenotrophoma maltophilia. Stenotrophoma maltophilia is the aerobic glucose non-fermenting gram-negative bacillus that is ubiquitous in water environment. It produces biofilm and the virulence factor that enable colonization and infection in vulnerable hosts such as those with underlying lung disease and person who inject drug and people with the hematological malignancies. Now, just like Acinetobacter baumannii, Stenotrophoma maltophilia has also faced many challenges. So first, the Stenotrophoma maltophilia is isolated from underlying pulmonary condition like cystic fibrosis and ventilator, those patients who are on the ventilator. So it is very difficult to say whether it is colonizer or true pathogen. and it recover as a component of polymicrobial infection. So Stenotrophomo maltophilia can be true pathogen that causes considerable morbidity and mortality, particularly in patient with hematological malignancy, where it can cause hemorrhagic pneumonia and bacteria. Second, treatment selection is hampered by antimicrobial resistance gene and gene mutation carried by Stenotrophomo maltophilia isolate. And L1 MBL and L2 serine beta lactamase render most conventional beta lactamases which are ineffective against Stenotrophomo maltophilia. L1 hydrolyzes penicillin, cephalosporin, and carbapenem, but not aztreonam. And L2 hydrolyzes extended spectrum cephalosporin and aztreonam. So Stenotrophomo maltophilia exhibit extrinsic resistance to aminoglycoside. So we cannot use aminoglycoside against the Stenotrophomo maltophilia. Then again, this Stenotrophomo maltophilia can accumulate multi-drug efflux sperm that reduces activity of septran, tetracycline, and fluoroquinolone, and chromosomal SMQNR gene that further reduces effectiveness of fluoroquinolones. Third, the standard of care treatment antibiotic regimen for Stenotrophomo maltophilia infection, against which to compare effectiveness of various treatment regimen, is not evident. So the general approach is we can use the any two of the following agent, that is cefiderocol, minocycline, trimethoprim, sulfamethoxazole, and levofloxacin, or combination of ceftazidime, avibactam, and aztreonam. So for combination therapy, we can use cefiderocol as a combination therapy, then high dose minocycline, trimethoprim, sulfamethoxazole, and levofloxacin. So not suggested it. Ceftazidime is not suggested for the treatment of this Stenotrophomo maltophilia infection due to presence of beta lactamase gene intrinsic to Stenotrophomo maltophilia that expressed to render ceftazidime inactive. As of 2024, CLSI breakpoint for Stenotrophomo maltophilia to ceftazidime are no longer available. Thank you, guys.